So today I'll be giving this talk on fluid responsiveness. Do you have to fill to the gills? So this talk I gave in Hyderabad on 23rd June 2019 in their Hicks meet. So I think we need to understand the meaning of fluid responsiveness. So fluid responsiveness is a physiological state where you look at the cardiac output responsiveness to the fluids that we give. So that is what we understand by fluid responsiveness. So we understand that giving less fluid in a patient who would need fluid to improve their cardiac output would be harmful. So if someone is fluid deficit and you are dealing with an unstable patient, not giving fluids would be harmful. But on the same note, if you give a lot of fluids, I think it is also harmful. So I think the main crux of the whole responsiveness is to give the amount of fluid a patient needs. It should not be less, it should not be more. So it should be optimal. I think that is where our whole effort has been over last 2 decades to see what is the best tool that we have which would determine the right amount of fluid that should be given. So giving more fluids, I think there are these three studies which have shown by giving more fluid, it can increase the duration of mechanical ventilation or it can increase the risk of patient going on a ventilator and it concomitantly increases the risk of mortality. And this has been found in all these groups of patients. So it increases mortality in sepsis patients, ARDS patients, patients with intra-abdominal hypertension or in acute kidney injury. So I think these are the situations we deal in ICU regularly, and these are the patients where we need to ascertain what is the right amount of fluid, because we wouldn't want patients to end up with overload or we wouldn't want patients to have less fluids on board. So I think that is where the whole efforts has been for last many years to see what is the ideal tool that we have to determine the optimal amount of fluid any patient would need. So I think the whole philosophy of fluid resuscitation or fluid responsiveness would be determined by this Frank Sterling curve. So if you look at this curve, I think there are two major domains that you need to look at. So you need to look at patient who has normal LV function. So if someone has a normal systolic function, then as you see, their response to a fluid resuscitation or fluid bolus would be very good, as opposed to patients with poor ventricular function. If someone has a poor ventricular function, then their response to a fluid, their cardiac output responsiveness to the fluid bolus would be suboptimal. And these are the patients where you need advanced hemodynamic variables to